South Texas Health System Children's, your child's health is our priority. When they're ill or injured, we're ready to help. Our team includes on-staff pediatric specialists in infectious disease, cardiology, orthopedics, neurology, ear, nose, and throat, and more. Our round-the-clock care features the Valley's first dedicated children's ER. For more than 15 years, we've offered healing and hope for kids. And we're here for your family now. South Texas Health System Children's.
Where kids come first.
Greetings and welcome to our latest Let's Talk Children's Health webinar. I'm Tom Castañeda, the System Director of Marketing and Public Relations for South Texas Health System. On behalf of STHS Children's, thank you for joining us. It's no secret children's health is essential. It impacts their development, well-being, and future health. Making sure they get timely developmental screenings and recommended healthcare services is key to catching health problems early when they're usually easier to treat. So to help parents prioritize their children's health, STHS Children's hosts these monthly Let's Talk Children's Health webinars. Through education on health issues affecting kids in the communities we serve, parents and caregivers can take action to help maintain the overall well-being of their kids. Now, in this installment, we'll be talking about diabetes in children. Being diagnosed with diabetes can happen at any age, but when it happens to children, the disease can bring on its own set of challenges, like developing nerve, kidney, and eye damage early in life. In the United States, approximately 352,000 children and adolescents have either type 1 or type 2 diabetes per the CDC. But a recent increase in the number of children with obesity has led to a rise in cases of type 2 diabetes in younger populations. So to learn more about the impact of diabetes on kids and the steps parents can take to prevent and treat the condition, we're joined by Melinda Barrera, a nurse practitioner with the Donna Medical Clinic, who is a certified nurse practitioner in advanced diabetes management. Thank you, Melinda. Here in the Rio Grande Valley, are you noticing that trend of kids now getting the type 2 diabetes?
Yes, we are definitely seeing an increase in obesity, in type 2 diabetes, even polycystic ovarian syndrome with the young teenage girls, and it's all related to insulin resistance that comes from obesity. So we are definitely seeing a huge increase in diabetes and younger and younger ages for the type 2. Today we're going to talk a little bit about both type 1 and type 2 just to differentiate, but there's a huge increase and it's all secondary to obesity.
Now, do you think that people understand the difference between type 1 and type 2 diabetes, or is there still some confusion surrounding that?
There's still some confusion. I mean, sometimes we'll have patients come in and say, well, I know I have diabetes, what type do I have? Automatically, a lot of patients assume that if they're on insulin therapy, they have type 1. But that's not the case. There is a differentiation between type 1 and type 2, and I would love to go over that with you. Our type 1 diabetic patients do not produce any insulin, and so they are dependent on insulin to live. So it is vital to their health, to their well-being. They cannot live without it. Type 2 is more related to our, yes, genetics, but more related to our lifestyle, right? Obesity is one of the risk factors. Being Hispanic is another risk factor, sedentary lifestyle. And so that they have a lot of options on medications. They don't need to be on insulin per se, but you can end up on insulin with type 2 in time.
If you're not careful and taking all of the steps that you need to take.
Right, because it's a progressive disease. And so if you've been type 2 diabetic for 20, 30 years and your pancreas is already given out, no longer producing insulin, you may end up on insulin. And so depending on where in the stage you were caught, right, on your diabetes, that can change. And so sometimes people don't take care of themselves. They are diabetic for some time, and by the time we see them, their pancreas is hardly producing any insulin, or whatever it is producing is not effective. So we need to start them on insulin early, even though they're not type 1. And so people get confused with what's type 1, what's type 2, Type 1 is very prevalent in children because it's an autoimmune disease, right? So the body just stops producing insulin. And so it's not necessarily, it's more of a genetic predisposition. And so with type 1, it's not something they did or didn't do, right? It's just an autoimmune disorder, and they're more than likely to have other autoimmune disorders later in life. So they will be insulin dependent from day one. Does that make sense?
Yes. And then the type 2 is the one where you can prevent it because you have that pre-diabetes stage right before you're diagnosed with diabetes. So if you're able to catch it early, you may never actually get diabetes, but you have to do everything you can to prevent it.
Yes, 100%. So you know that a lot of times with our type 2, even in that pre-diabetes stage, like our body is always, it's beautiful because it tries to compensate for us. And so what happens is before you're even pre-diabetic, for anywhere between 5 to 10 years, your body is producing excessive amounts of insulin to control the glucose.
Oh, wow.
So it's overworking, it's overtime. It's working overtime on producing more insulin. So that's when you'll have like the darkening of the neck, some darkening here, the axilla, the weight gain, because insulin makes you gain weight. Because your body is trying to control that glucose. What happens is that after a certain amount of time, your body's like, okay, you know, I can't keep up. I'm producing it, it's just not working. Then you have obviously the overweight, the obesity, and so then there's insulin resistance. So you may be producing a lot of insulin, but there's some resistance, it's not working properly. And what insulin does in our body is basically it opens up the cells to receive the glucose.
Okay.
So glucose is our energy, it's our fuel. And so when our body works properly, the insulin opens up the gate, the sugar comes in, and our body is able to, you know, have our heart beating, our kidneys functioning, we're able to work properly. When the sugar is high, what's happening is the insulin is either not being produced enough, we don't have enough insulin production.
Okay.
Type 1, they don't produce any, right? So they have to inject. Or whatever you are producing, it's kind of like the key's not going in, and it's not opening that door so that the sugar can come in.
Okay.
So when you check your glucose and you're at a 300 reading, what does that tell you? The sugar's not getting into your cells. So your body thinks, give me more because I don't have fuel. I don't have the sugar that I need. So your body keeps asking you for that sugar. And so a lot of times our diabetics are not able to control that, right? Like they're eating all sorts of foods. They're not able to control that appetite because their body is telling them, I'm not getting the sugar because it's not getting into the cells. It's just floating around.
And it's the body confusing you to think that you want more food, but you really don't need more food. You just need to have more insulin.
Right. And there's medications. If it's type 2 diabetes, I mean, there's medications that help whatever insulin you do produce be used properly, right? So you do have oral medications. We have the GLP-1 receptor agonists that also help. There's a lot of options on treatment options for type 2. For type 1 is where really it's just insulin because they don't produce any, right? And so for kids, it can be very burdensome, right? To have to be injecting themselves, to checking their sugar, to counting their carbs, to knowing how much to inject. But with education, they can do really, really well in time. And I think if diagnosed early, they become experts. You know, as long as they have good family support, because it is something that's going to affect the family, they do really well. With our type 2, it's different, right? Because it's about changing habits. It's about changing our relationship to food, our relationship to our culture, Hispanic culture too, right? Tortillas and whatnot, rice, all the things that we love to eat and are part of our, you know, culture and part of bonding.
They're at every fiesta you go to, every family gathering, and so they're hard to avoid.
Exactly. They're hard to avoid, and then there's some judgment like, well, why aren't you going to eat this? You know, I just made it for you. And so really education is so important, right? Talking to our family and getting support and really saying, you know what, okay, like it's not that I don't want to eat, why don't I just control my portions, right? Why instead of having 3 tacos or, you know, even not eating the tortilla, I'll have a little bit of rice, but I won't eat the tortilla or whatnot. So really having these conversations and educating our families, our caregivers, our moms or whatnot. Hey mom, you know what? I realized that, a corn tortilla is converted into 6 teaspoons of sugar, and
Oh,
a
wow.
flour is converted into 12 teaspoons of sugar. And the things that we don't know, right? And what our body does with it. And so education is so important, to bring awareness and really to change what we're doing on a daily basis. I don't know if that's something that you feel like would help.
No, that education is really important, and you do have a great presentation for us that you've put together to kind of just help the community understand type 1 and type 2 diabetes. So let's get started.
Yeah, let's get started. So we're going to talk today, really like I mentioned, about education regarding diabetes in children. We have multiple types of diabetes. Type 1, type 2 is what I'm going to be talking about today. The causes, how the diagnosis is made, treatment and prevention options. So like I mentioned earlier, Tom, diabetes is a condition where the body cannot properly process glucose. And so you have elevated blood sugar levels in the body. And so your body basically starts burning fat for energy instead of the glucose. We have, like I said, type 1 and type 2. And what we know is that type 1 is the most prevalent and most common form in children. We have 80 to 90% of type 1 diabetes in children. There's approximately 18,200 new cases every year. And like I mentioned earlier, type 1 diabetes is an autoimmune condition where the body attacks insulin-producing cells. So the beta cells are no longer existent, and our patients are required to inject insulin. With our type 2, the body becomes resistant to insulin, or it doesn't produce enough. It's often associated with obesity and a sedentary lifestyle. It's increasing among the youth, particularly in certain ethnic groups like Hispanics, African Americans, Native Americans. We have about 10 to 15% of type 2 diabetes in children, and there's approximately 5,300 new cases per year. This has pretty much doubled. So we are seeing it increasing significantly in the last decade. For the risk factors for diabetes in children, so type 1, like I mentioned, it's an autoimmune disorder. It tends to happen in families, so there is a genetic predisposition, but it can happen to anybody. So it doesn't necessarily have to happen, if my brother, my sister, my mom had it, doesn't mean you're gonna get it, but we do have a tendency to see it be a genetic predisposition. With type 2, we know there's certain risk factors, right? So being overweight, being obese, having a sedentary lifestyle, having a family history of type 2 diabetes is a risk factor, whether it's in children. And you can associate it to lifestyle, right? So like if, your family eats a certain way, well, that's how you're brought up eating. And then so you see a lot of people doing that. We also have certain ethnic groups, like I mentioned, the Hispanics, African Americans, Native Americans are at higher risk for type 2 diabetes. To talk a little bit, type 2 diabetes and type 1 both come with some complications. The most important thing with diabetes is making sure that they're controlled. If our patients are controlled, a lot of these complications are decreased. So you're not going to have a lot of these complications so long as you're controlling your sugars. Some of the short-term complications are your low blood sugar, which is hypoglycemia, and that can be life-threatening if your sugar drops significantly, like below 40, right? You can end up in a coma. High blood sugar is hyperglycemia. That's very dangerous as well because it affects your organs. You can also end up in a coma if it's extremely high, like above 600. And then diabetic ketoacidosis is a medical emergency. What's happening there is that your body is actually burning your fat for energy. So you end up with ketones. You're peeing out ketones. So this is something that you can actually die of. This tends to happen a lot in type 1 diabetics when they're not aware. They don't even know it, right? So they'll end up in the hospital. They're going to get fluids. They're going to get insulin therapy, but it's all titrated, and it's, you know, very, very dangerous. For our long-term complications, we can have, you know, retinopathy, eye damage, kidney damage, nerve damage, and heart disease. And so, you know, the biggest risk factor for diabetics is cardiovascular disease. And so we know that they're 2 times likely to have a heart attack or stroke versus someone who's non-diabetic, right? So it's super important to control our glucose, just because cardiovascular death is so prevalent in these people, and it's a silent killer, right? Like, you may not have any symptoms, but just being diabetic is going to put you at risk. So some of our warning signs and symptoms that can go unnoticed a lot of times, you may have increased thirst and urination. A lot of times we think, well, I'm just thirsty because it's really hot, especially here in the valley, right? Because we have a lot of hot days here. So you think that you're urinating a lot because you're thirsty. You're tired, you're irritable, you may have some blurred vision, you get sick often, you have unexplained weight loss. So because of obesity, like we talked about, a lot of times people are like, hey, I'm losing weight, I'm doing great. And so what we're realizing is that when you're getting up at night to urinate, you're very thirsty, you're just drinking all the time, and you're losing weight, that's a red flag. So the only things that can be causing something like that is either diabetes, thyroid issues, or some type of cancer. So you need to go and get checked, right? For our parents, especially with your children, if you start seeing that they're just losing weight, and you know they're eating and they're excessively hungry and they're eating a lot, you got to take them to the doctor. Because sometimes we think, well, they're very active. I mean, children can do a lot without any symptoms. So we need to just always have an eye on them and be alert and seeing what's happening with our kids. Why are they changing? Are they eating more? They're losing weight. I mean, look at their shirts, look at their pants. How is it fitting? It's a huge red flag when you see your children losing weight and they're just eating a lot. With type 1, these symptoms can develop really quickly. So a lot of times you may not notice, right? And it's, like I said, it's life-threatening. So super important. You can even check their sugar. And if you see that their sugar is above 200 at any given point, that's not a normal reading. With type 2, it usually tends to be a slower development. You won't have like an acute sudden rise or sudden weight loss. It really takes some time. So really with our type 2, what we'll see is that they'll start getting the darkening around their neck because of the insulin production, or they'll get like darkening in their axilla, their groin area, and that's just their body compensating and producing excessive amounts of insulin, which is going to cause them to gain some weight. The other thing, your kids may also have like some tingling in their limbs, and maybe like blurry vision. So those are just red flags. The diagnosis for diabetes in children, there's multiple ways to diagnose them. You can, like I said, you can have a random blood sugar level of 200 or higher, and that suggests that there might be some diabetes there, unless they're on steroid medications for asthma or some type of virus or something. That is not a normal reading. If they have a fasting blood sugar of 126 or higher, that indicates diabetes. A normal reading is less than 100, so anything between 100 and 126 may indicate prediabetes. The A1C test is a test that reflects what your average sugar has been for the last 3 months. And so a normal reading is less than 5.7. Anything above a 6.5% or higher indicates that you are diabetic. And that really gives us an average of what you've been or where you've been for the last 3 months. For our type 1s, on top of your A1C or your fasting blood sugar, they'll do some confirmatory testing for autoimmune disease. So for our children, they'll do a GAD, ICA, IAA, a C-peptide, which are basically autoimmune markers that will tell us if there's an autoimmune type of test that is showing that you're type 1 diabetic. And then, of course, the most important thing when we're doing these tests is to check your medical history and what symptoms you're having, right? Like, how is this patient presenting and how urgent is it that we get them to the hospital if they're type 1? So how is diabetes treated in children? Type 1, like I said, it's insulin therapy. They're going to need basal and bolus. So basal is a once a day injection, and it's going to provide a little bit of insulin throughout the day. And then you have the bolus, which is for every meal. Now we have insulin pumps. So a lot of times our type 1 diabetics are on insulin pumps. And so that's just administering a little bit of short acting insulin continuously. And we have what we call the CGM. It's the continuous glucose monitor. And what that is it's a little monitor that's continuously checking their sugar so that they don't have to be poking their finger 24/7. And that's just a way to kind of save them a little bit of injections. So they have to be regularly checking their blood sugar continuously with every meal to know how much insulin they're supposed to be injecting. And they have to have a healthy diet and physical activity. So type 1 requires a lot of work and education, but they can live very healthy and perfect lives. With our type 2 diabetics, it's a little bit different, right? Because lifestyle modifications can go a long way for our type 2s. Diet and exercise are huge. You can take oral medications or insulin if necessary. I think if caught early for our type 2 diabetics, we can make significant amount of changes in our habits that can really change the trajectory of our lives, right? So that's not to say that you may not need, that you don't need medications. That's just to say that you can really change how many medications you're going to need going forward, and also how we can prevent a lot of the complications that come with type 2 diabetes, which is kidney damage, heart damage, amputations at times, nerve damage, and vision problems, right? Retinopathy, a lot of blindness. So monitoring for and managing comorbidities with both. We tend to see more of the comorbidities in type 2 because they'll have that hyperinsulinemia 5 years before they're even pre-diabetic, and then they're pre-diabetic for a good 5 years, and then they're diabetic. So there's been like a 10-year damage of high insulin levels and high sugar levels. Then we have for prevention tips and managing diabetes. So obviously a healthy lifestyle, balanced diet, rich in fruit, vegetables, whole grains, encourage physical activity, maintaining a healthy weight. What I do want to talk about on the physical activity, you know, we are seeing a lot of children spending times in front of computers, gaming, Xbox, I don't know, PlayStation, or on their phones. And so they're not moving very much. So that is just not helping in keeping our bodies active and in burning calories, and especially with fast food and, you know, with what our diet consists of, we're really having this sedentary lifestyle affect our blood sugars. The other thing is regular checkups. I mean, I know we have annual screenings for children where they're supposed to be going to the doctor and getting their wellness checkup. That's super important for early detection. If you're type 1 diabetic, then monitor your blood sugar levels consistently, and obviously taking your medication. And then empowering our children and our families with knowledge about diabetes management, and then emergency preparedness. So what do I do if my child's blood sugar is 40? How do I treat them? So how do I, you know, have, you know, an glucose pen if I need to inject them with some sugar, if their sugar is dropping? So education is so important, and reaching out to diabetes educators, to nutritionists, and really involving the family is so important, because it's got to be not only a lifestyle change, it's got to be a family effort, and really empowering our children and our parents and our brothers and sisters to participate in our well-being. So, do you have any questions for me, Tom?
I have so many questions
All
for
right.
you. That is all great information, though, and I think it's really helpful that you are able to explain the type 1 and type 2 diabetes difference so that the families who are watching can understand. Now, obviously, we talked about Latinos being more impacted, so Hispanics, and we talked about diet being an issue. Are there any other reasons why we're seeing that it's impacting Latinos so much more?
Diet and then just the sedentary lifestyle, I think, is 100% affecting us, where the weight gain, right? I think the social, like I mentioned, the social media, where children are just not moving
As much as they used to.
as they used to, exactly. So we need to spend more time outdoors. Like, we need to be active in getting outdoors, in moving our bodies, whether it's on a bike or, running, soccer, just getting outdoors and spending time outdoors, moving our bodies, because we're not moving. And I think also educating our families, like I mentioned earlier, I think a lot of times we're not aware with what
We're putting on a plate.
Right, what we're putting on our plate. Like, we think, well, I just had, 1 flour tortilla. Like I said, that's converted into 12 teaspoons of sugar. And you wouldn't put 12 teaspoons of sugar, without saying, well, that's a lot of sugar, right? But we are eating it in our tacos. We are eating it with our meals. With the Latino, a lot of our culture, everything we eat is with tortilla and rice. And that's all carbs, right? And so that's just spiking your glucose up. And when your sugar goes up, your insulin goes up. And when your insulin goes up, you're going to have weight gain. So it's just, it's a circle, right? And it's just something that when we are not aware, we're doing these things, and we're not aware that we're hurting our children when we're giving them these foods. Does that make sense?
That does. And the funny thing is, I heard a friend recently asked me, could you eat 16 corn tortillas at one sitting? And I was like, no, that's a lot of corn tortillas. And they said, well, you're eating them fried when you're having chips. So even just, you think tortilla chips and the salsa, like, that's cut in fours. Are you eating if you start doing the math, you're like, wait a minute, I actually could have eaten probably like 6 corn tortillas today at lunch without really realizing it.
That's a really good point. And who doesn't love chips, right?
I know, right? But then
With
you're
the
like,
salsa.
and then they're also fried, and so you're throwing in that as well, and so
On top of it, and then that's the thing. Like, that's a culture thing, right? Like, that's just for us. It's, like, let me just dip some salsita, and have that, and then it's like you can't stop. You have one, and then it's just another and another. And how many tortillas does that become, right? So that's just spiking our sugar levels. So making a conscious effort to decrease that, just being aware, and then educating our children, right? Because I think, like, we set the foundation for them, right? Like, we have a lot of power as parents, as mentors, in teaching them how to eat right and how to eat better, and we have to do it too, right?
Be a role model.
Be a role model. And then, like I said, a lot of times, it's our culture. Like, this is done with love, like buñuelos, right? Buñuelos. I mean, that's like a fried tortilla with sugar, right? And so, like, it's like, I can't wait for Christmas so I can have that, but it's so bad for our health. So how can we choose better foods, make better choices, right? That's not to say that you can't have some. It's just to say, like, let's try to make better daily choices so that when Christmas does come, you can have that, or tamales, or barbacoa, right? So I think in the Hispanic culture, that's one reason, right? Like, we're not moving. So the diet hasn't changed per se, because it's obviously, but people were moving. They were working in the fields. They were working outdoors. They were doing construction. They were physically active. What's changed? The activity has changed. We're not active anymore. I think that's part of, like, the risks, and that's why we're seeing a huge increase.
And when we talk about the obesity that unfortunately we're seeing in our country, they had to coin a term, diabesity, because the correlation between obesity and diabetes is so close.
President, it is so close. The problem with obesity is we associate it a lot with our choices, and yes, our choices do have a lot to do with it, But when you're looking at diabetes, right? Like I mentioned earlier, so if your sugar is high, meaning it's not getting processed, it's not getting used, my cells, my body is telling me, I need more sugar. Give me food, because I don't have the energy, I don't have the fuel. And so your body is asking for more. So it's a disease. Obesity is a disease. It's not just a decision. Does that make sense?
Yes.
And so understanding that we need to treat obesity as a disease just like we treat diabetes. Because even though people can make better choices, so we do.
Sometimes the brain
The body
in
is
the body is
the
tricking
body
us.
is working against us. Exactly, it's working against us. So let's bring awareness to understanding that it's a disease. So we need to work together. Yes, we have power, and we should empower our patients and our children and our families to make better decisions, because that does matter and it does play a role. But it's not all of it, right? It's multifactorial, and there's a lot of contributing factors. There's hormones, there's genetics, there's lifestyle choices, there's physical activity, there's sleep, right? You're not sleeping well. You're more prone to gaining more weight, you know, because your stress hormones. So there's just so many factors, and we need to do a better job in educating our families, and then and being proactive, right?
Now, when it comes to the risk factors, obviously we've talked a lot about weight and maintaining a healthy weight. But when you're talking about kids, obviously you have those growth spurts that may happen. But with that weight, is there an area in particular, like the abdomen, where if you're noticing it in the abdomen, because you can look completely healthy and then you get a BMI check and it'll be a little high because maybe you're carrying a lot of weight in your midsection.
So central adiposity, which is, you know, the weight retained in the abdominal area, is related actually to cardiovascular disease. And it's so where you're gaining the weight does tell us if it's not that it's healthy, you know, it's not like, oh, if you gain weight here, you're healthier. But central obesity is related to cardiovascular risk. You're at higher risk for cardiovascular disease, and more likely to have, you know, metabolic syndrome, diabetes, cardiovascular disease, chronic kidney disease. So on top of our BMI, because you could be a BMI that's elevated if you're muscular, right? Because muscle weighs a lot. So, and your BMI can also be normal, but you have, you know, your waist is a little big, right? So like your weight is all here. And so that's not healthy. So we need to work on how to define really obesity per se, right? Because someone can just be very fit and very muscular and have a BMI that's elevated, but not necessarily be obese, right? And vice versa. You can have a normal BMI, but your weight distribution is all centered. And so you're actually high risk for having, you know, some diabetes or whatnot. So weight and BMI are not the greatest predictors, right? And being healthy, sometimes you know, it's not something you just visually see or you can just see on a scale.
Yeah.
Does that make
No,
sense?
of
So
course.
now you have a lot of like those scales that kind of tell you your fat distribution, your muscle mass, and gives you a better idea of where you're at.
Yeah. Now, let's talk about the symptoms again. So it's really important to understand those, so that increased thirst. So it's a thirst that is not necessarily associated with them having been outside playing. This is a thirst that is consistent throughout the day.
Yes. So this, I was going to say, because I've actually seen it, where they're just, you know, drinking, and you're going to see them go to the restroom just consistently. Like in this hour, they would have gone 3 times, and then you'll even
drinking.
sometimes see them where they're
Yeah.
just kind of like dry mouth.
Yeah.
And that's why they keep drinking the water. So they're going to have like a dry mouth. They're going to consistently be going to the restroom. Sometimes they may have like a fruity odor for our type 1s, which is telling you that it's a diabetes. And it's not just, oh, I'm thirsty because I was out in the sun or whatnot. This is continuous. This is all night. This is all day. AC, no AC. It's 24/7.
And you may notice bedwetting for somebody that is potty trained. Like you may notice that they're wetting the bed as well because of that frequent urination.
And then asking for more water. Mom, more water, more water. I want more water. I'm thirsty. And it's just continuous. So, and then the biggest thing there, on top of the frequent drinking, they're also very hungry, eating a lot, but not gaining weight. And so in children, the best way, because you may not notice it because you're thinking, because they're going to be physically active. They're just children, you know, are like, they can just do things, right? But you may notice their clothes is fitting differently. Like, okay, why is this a little loose? You know, I mean, you're eating right, you're drinking. Like, why is your clothes fitting so much bigger? So that would probably be like a big indicator.
That's a red flag.
It's a red flag. Like, why? What's happening? This is not normal. And it's going to happen fast. It's not going to happen like slow with type 1.
And of course, you also have that fatigue, and you think, oh, maybe they didn't sleep well. But if it's a consistent fatigue that you're noticing, or that irritability, that's when if you're noticing it consistently.
Right. So you may even say, like, well, their personalities are changing. Like, why are they so upset all the time, or they get angry over nothing? I just want to sleep. I'm so tired. I'm so tired. In children, that's not normal. Right? Especially if they're doing nothing out of their ordinary routine. So those are super red flags, and you need to take them into the doctor.
All right. Now, if a family member has type 1 diabetes, is their child at risk?
Yes.
Okay.
So it is genetic. I mean, there's a genetic predisposition. That doesn't mean they're gonna have it, but they have a 50%.
They're a 50% chance of having.
There's a higher risk if your parents have it, or a sibling, right?
And now that's obviously type 1. Now type 2 diabetes, if my parent has type 2 diabetes, does that mean that I'll get type 2 diabetes? Because obviously that one comes on with a whole different situation.
So you are at risk, number one, right? You are at risk for multiple reasons. Genetics play a role, just like the color of our eyes, right? But the other thing, like I mentioned, is in families, we tend to eat what our parents eat, right? And so on top of the fact that you have a genetic predisposition, we're also doing most of what we were taught, or eating most of what we were taught. So with type 2, environmental and lifestyle has an effect.
Those factors
right,
play
it has
a role.
those factors. And so unless you're very conscious and you say, you know what, like, I don't want to have type, and my mom had a lot of complications, I don't want to go there, and you start very early on in changing those habits, you may change the trajectory of your course. But you are at higher risk if you have a parent, or both parents, or aunts and uncles, grandparents. You have a higher risk of having type 2 diabetes.
So let's say you have that family history of diabetes, and how often then should you check your kids with like a blood glucose test, let's say, or a screening?
So with our children, you know, it's a good question, because with our wellness screenings in children, when we do the annuals, right, and they get their vaccines or whatnot, we don't necessarily draw blood. You may do like a CBC, which shows you if they have anemia, but it doesn't show your sugar. So I actually don't know the recommendations as far as like how often they need to get their blood test. They do get it when they're newborns or whatnot, but if you see that your child is obese or overweight, you can have once a year screening. Unless they're having signs and symptoms, you don't wait.
You need to be doing it
Yeah,
sooner.
you don't wait. I mean, if your son or daughter is having symptoms, and I mean, you can check that a lot sooner, talk to your doctor and say, hey, you know what, I'm concerned. This is what's going on. Can you please just do like a wellness check? And they can check everything.
Because obviously you have the stages. So the blood glucose is one. I know we offer the no-cost health screenings at our event. It's something you get the prick, you read your number, and you're able to tell.
And that's a good idea. That's a good indicator, and it's quick, and it's not expensive, or and so that's a good baseline.
Yeah.
And you can do that as often as you'd like, really, because there's no, like I said, unless something changes in the child. Or, obviously once they're 10, where their bodies start to change and there's like hormones or whatnot, then it's a little different, because then they're starting to grow, like they have those growth spurts, and you can do real like blood work more often.
Yeah.
Versus the younger.
And then that A1C obviously is giving you your blood sugar levels for the past 3 months. So you're getting a more defined reading, because that one screening, if you do the blood glucose test one time and it shows that you're high, that's not necessarily cause for concern, because you may have eaten a lot or whatever it may be. But if you're getting 2 or 3 or 4 of them.
Right. So the random blood sugar, which is just irrelevant of when you ate, right?
Yeah.
If it's above 200, that's not normal, but medications can increase that.
Okay.
Stress can increase your sugar. Certain things can increase your sugar, right? So that's, if we do a random sugar and it's 200, we would say, okay, when did you eat? What did you eat? Well, I just had a pizza, or I just had spaghetti.
Yeah.
That's going to cause an elevation, right?
spike.
And so we need to know how much time has passed since, and so that'll tell us. Now the A1C gives us an average of the 3 months. So you can't really lie there,
Yeah,
right?
exactly.
Because it's going to give us an idea of where your body has been for the last 3 months on average. So you may get actually a normal reading there if you're a yo-yo, like if you have a lot of highs and a lot of lows, a lot of highs, a lot of lows, and it'll look like you're controlled, but you're not. But regardless, it'll give us a good average.
Yeah.
So that's a good indicator, or a better idea of where you are versus what happened today, or what did you do today, or something that can change based on what you were eating a little while ago, right?
All right, now you take your child to see their pediatrician, they're diagnosed with diabetes. What advice do you have for explaining the diagnosis to their kids? Obviously, you talk about understanding it and educating them as well, not just the parent, but also the child. So what is your advice for that?
So let me ask, so are we talking type 1 or type 2?
Type 1. Let's
Okay,
start with type 1.
let's start with type 1. So with type 1, because it is going to require injections, it's going to require checking your sugar, and it's going to require lifelong treatment. Like, we need to first make them feel like it's not their fault. Because a lot of times it's like, well, why am I having to do this? And they're going to be different. I mean, at schools, they're going to have to be injecting, or they're going to have to be on their pump. So there's a lot of education there, and we need to really make sure that we're also addressing their emotional needs. So explaining to them, look, your pancreas was in charge of producing insulin to control your sugar, but now your pancreas doesn't do that, right? It's not your fault. So to make them feel like this is not a punishment, right? This is something that just happened. It can happen to anyone. Obviously, if you have relatives that have that, then we can use the relatives as an example. So helping them understand that it's not their fault, and that it's going to require, for them to be checking their sugar, for them empowering them, right? That they have control, that they can make better choices, but they're always going to have to be injecting, and they're going to be dependent on insulin to live. So insulin is going to be like their oxygen, like they need it for life. With our type 2s, it's a little bit different, because they can do certain things to help improve their life and possibly not need medications, right? So they can really change the trajectory of where this is going to go, right? Instead of going into the heart disease, kidney failure, or whatnot, what can I do to make this better? So exercise, diet. Those are two of the most basic things, but also really changing their relationship with food and whatever is triggering them, right? So if it's just, I just want to be on the phone, or I just want to be playing games, I don't want to. So we need to change that, right? How can we be better in taking care of our bodies? And like I said, I think with children, family is huge. Parents are huge. They play such an important role in molding their children's lives and in empowering them. So it's a conversation, yes, with the child, but I think it's even more of a conversation.
With the entire family.
Right.
Because abuelita can't be offering them a
Pan dulce.
galletita or whatever, a pan dulce.
Right. So
Yeah.
we need to this is a conversation for everyone.
Yeah.
So yes, the child may be the one that's getting the diagnosis, but the treatment is for everyone. The unit, the full family, everybody that lives in that house. We need to talk about sodas. We need to talk about chips. We need to talk about tortillas. We need to rice. We need to talk about what we're doing, what we're bringing home, that's putting our children at risk.
Now, when it comes to obviously managing the disease, technology has advanced so much now. So you have the insulin pens, the pumps, you have the rapid acting inhaled insulin. So there's a lot that's changed. So it's not as cumbersome as it used to be
Yes.
back in the day.
100%. I was gonna say, so a lot of times insulin is seen as like a bad guy. Insulin is life-saving, and now we have inhaled insulin as an option, Frieza, and our basal insulin used to have to be injected twice a day. Now we have basal insulins that only need to be injected once a day. We also have insulin pumps, which basically you wear and are continuously giving you short-acting insulin based on your readings. So you don't have to be injecting yourself every time or carrying your insulin around or whatnot. So that's a huge advantage to these children. And then, like I said, like, because our type 1s have to be checking their sugar to see how much insulin they need, we have the continuous glucose monitor, which is also a little monitor they wear that's checking their sugar nonstop, right? So they don't have to be poking themselves as much.
Yeah.
So these are huge advances. It doesn't resolve the issue, but it just really makes their life a little bit easier, and it just makes it more manageable for them and for their families.
And when managing the condition, obviously children are growing, and so you have to constantly be monitoring their weight and all of that, because that will those adjustments will need to be made with the insulin. Is that right?
That's right. So insulin is weight adjusted. So definitely when they're growing, especially in our type 1s, hormones play a role. They can increase your sugar. You can have spikes. With the ladies, with the girls in teenage years, you know, their hormones, when they're on their menstrual cycle or whatnot, I mean, their sugars are going to be changing regardless of what they're eating. So it's not just food, it's their hormones. So we definitely need to be working with an endocrinologist closely to make adjustments on our pumps, if they're on pumps, or even to make adjustments on what we're injecting, you know, with our meals, our bolusing, or basals, just because of the weight gain, like you said. Now, the other thing is with insulin makes you gain weight. And so here we are, you know, talking about obesity. And if someone's on insulin, then we're also like not helping them with their weight.
Yeah.
So I used to see a lot in my practice when I practiced with type 1s that they wouldn't inject as much because they didn't want to gain weight. And so then they would have high sugars, right? And so helping them have a healthy relationship with their diabetes type 1 and understanding that we need to control your sugars to prevent, you know, all these complications that are going to come. Because unfortunately weight and, you know, our image or whatnot is a huge factor, especially in such a susceptible age. Like they're so young, they're teenagers, image is very important to them. So all of the education that we can get, the mental health awareness with these little fragile minds, and being as positive and empowering them and making them feel that there's nothing wrong with them, right? This is just something we're gonna do together and improve through our lives, right? Like, so trying to get them healthy relationship with their diabetes. So
yeah. Now, when it comes to parents, obviously some tips on helping them manage their children's diabetes. So obviously learning to count carbohydrates. And so that may actually involve you adapting the menu for the whole family and how the entire family eats, right?
Yes, so counting carbs is something that I always recommend for them to go and talk to a nutritionist and sit down as a family, like mom, dad. It is unbelievable how parents do not understand this, right? But when you're injecting insulin, you need to have that knowledge and you need to understand it. If your children are very young, if they're 5, 6, and 7, you need your parents' support, right? We've had patients that have over-injected and ended up in a coma, right? Because they didn't know, or they didn't eat, or they injected and then they forgot to eat. They got busy, they got distracted. So parents are so important in helping their children with the carb counting and also with their insulin injections, right? Until the child is ready, a lot of times parents will do it for them.
And that's why it's important to learn how insulin works and how you should be eating, when you should be eating, and when you should make sure that you're getting the insulin pumped at what times, and being consistent and keeping that routine.
Exactly. So some insulins are short acting and some are rapid acting. So you have a certain amount of time before it starts to work, and you have to know when you have to eat, how much time you have to eat before it starts to work, and then your sugar starts to drop.
Yeah.
So educating our patients when they're on insulin and understanding that, hey, like this is what I'm going to give you. You can't inject and then go do like your chores or go for an errand or get distracted. Like you need to have your meal ready to eat.
Learn how to check your child's blood sugar and interpret the results. So not just taking it, but also understanding what that number means.
Right. That's 100% key in controlling your child's blood sugar throughout the day. So if your child is at a 200, not only do I have to fix that elevation, I also have to fix what they're about to eat, right? So I need to account for where they're at and then what they're going to be eating. So that's super important. Education is huge in teaching them, and we need to have parents that are willing and are going to be very involved in their children, in their child's care.
Yeah, and then obviously understanding how different foods, exercise, and illnesses can affect your blood sugar levels.
Yes. So a lot of times with our continuous glucose monitor, the benefit of that is that you see which foods are spiking you and dropping you, and how foods are affecting your sugar, right? So it's very easy to see when you download that. You're able to say, okay, what happened? What did you eat yesterday at 1:30? And they're like, oh, well, we went to, celebrate grandma's birthday and we had a piece of cake. Okay, well, look at what happened. Your sugar went all the way to 300. And then, oh, look, you were really controlled on this day. What did you do? Oh, well, we stayed home and I really did. So with the continuous glucose monitor, you're really able to see how foods are affecting your sugars. And that's essential, right, to controlling them.
And lastly, obviously, you have to manage rivalries and feelings of jealousy between siblings. So you have a child who's been diagnosed with type 1 diabetes, and you have another child that doesn't have it. They may, there may be some issues with that, with jealousy of, I can't have that and you can. So learning how to manage that or avoid it altogether.
So I think that's going to be tailored to like the family, right? Because I think it's going to depend on those conversations that we have with the children and with the parents, and really what their approach is going to be. Is it going to be like, you know what, we're in this together and we're all gonna do the same thing, or hey, we're gonna help you, but I don't want to. I really feel like it's got to be a family effort, and it's got to be let's just do better. Now, I think there's always exceptions and there's always celebrations and there's reasons when we can have the cake or we can have this and that. And what we try to do there is, we give a little bit of extra insulin. That doesn't mean we're going to do this every time, but we're humans and we're allowed to, to celebrate sometimes and to have a little bit of carbs here or there, obviously, right? But not punish the child or the family, and really just having those conversations where if my sister's having these foods, why can't I have them? Well, you know what? Your sister's not doing what's best for her. How can we help her, right? And educating the full family.
All right. Now, we do have a question from the audience. Any meal plans available for the public? Any place that they can go to sort of get meal plans that are good for a family with a diabetic child?
Great question. So I have some resources.
I know the CDC always has a great website where you're able to get information.
Yes, the CDC has a great website. You can use the ADA, although the American Diabetes Association, that's another website you can use for meal plans and recommendations. I would also recommend, if possible, going to a nutritionist locally. We have some great nutrition, a great nutritionist here in the Valley, and sitting down, and they will do like a one-on-one. I think if you don't have insurance, it's like $50 a session. But you can bring your parents if it's for the child or if it's for husband or wife, and you can go in there together and really like talk about and tailor what you guys are already doing and how you can make modifications, like small modifications. I think it's worth the investment and the time to learn how to eat properly and what to do. So we need to tailor it to our needs.
Exactly.
Does that,
you can find a great recipe online, but
Right.
when you speak with a nutritionist, they understand what you like, you know, what your child may like and your children may like. And so they're able to say, okay, you like a lot of this, they can give you substitutes for it. Like,
Exactly.
I heard that beets can actually be a substitute for potato in potato neck, you know, tacos. Not that you should have a tortilla, but.
And beets are really good, by the way.
I love beets.
they're so good and they're so beneficial for our bodies and healthy. But I don't want to say there's a specific meal plan. You can use the websites, like you said, the American Diabetes Association, the CDC, they'll have something general. But I think for diabetes and just to tailor it to what you guys are already doing and make sure that it's individualized and that you're going to be able to make these changes, not just for this year or for this month, but incorporate them into your life and into what you're doing every day and how we can become better as a family, as individuals, and, you know, as humans.
And then in terms of prevention, I did find the 5-2-1-0 rule for healthy goals, which I thought was really great. And so this one says you should have 5 servings of fruits or vegetables, so that's really key. You should have 2 hours or less of screen time a day. We talk about not having a sedentary lifestyle, that's really important. 1 hour of activity, so your child should be having 60 minutes of activity a day, so that's really important, and 0 sugary beverages. So those are at least some good starting points before you can talk
really
to
like
your,
that.
I'll give this to
I
you.
really like it.
It's a good one to have, and I think that's really important.
Yes, I really like this. I think, you know, one of the things I said I was going to do this year was spend more time outdoors with my children. So super important. The fruits, vegetables, we got to start young, right? Because a lot of times they don't like it. But start with vegetables first because then they're just going to want the fruit because it's sweet and it's, you know. But yes, I really like this, and I think that if we just stick to this, simple, and we're able to incorporate this into our daily life, what we're doing every day is really what matters. It's not what you do once every 3 months or what you do once a year. It's every day having healthy practices, healthy habits. That's what's going to make the difference.
And last question, when should a person go to the ER? Are there any issues that you see, any symptoms that they're noticing where it's like, you know what, it's not just going to your doctor, it's going to an ER?
So for children.
For children.
For children. So I would say if your child is, you know, like I said, so they're excessive urination, excessive thirst. If you happen to check random blood sugar and they're above a 200, you need to go get checked, like stat. They may need insulin, they may need fluids. If they're starting to get unconscious, they're starting to get weak, you start seeing their ribs, because I'm telling you, with type 1, it happens really fast.
Okay.
Like they'll lose 20 pounds in 2 weeks. And they're eating, like they're eating. Like that is a medical emergency.
Yeah.
That is not something that you can, let me go to the doctor. Like, no, you need to get into the hospital because they need fluids, they need insulin, they need to be treated ASAP. So number one is just knowing your children and seeing them, right? And really seeing like what is their normal and what is their not normal. So they may not be telling you anything, but you're seeing, hey, my son is in the restroom 24/7, they're eating, they're always hungry, and they're always thirsty. Like those are key symptoms: always hungry, always thirsty, and always urinating, right? Fatigued, irritability, may have blurred vision, excessive weight loss. Nobody loses weight with excessive eating unless they're diabetic. So sometimes people are like, oh, no, this is right. No, that's not normal, right? So that needs to be, that's a medical emergency. And then if they collapse, you know, they may end up in a coma, whether it's because of excessive hyper, or hypo, if they're just non-responsive or they're slow to respond. That's a medical emergency. You've got to call the ambulance. You don't even have time to drive. You call the ambulance so they can start checking them on their way there, right? Whether it's their sugar, blood pressure, their vitals, and all of that. For more complex, obviously, people who are diabetic and have been diabetic, anybody who's having a stroke, obviously, like they're not able to, to express themselves, but this is later in life. This is like adults, not children. This is not likely to happen in children, unlikely, because with type 1, it really will take 5 years before we even have to screen them for their eyes, just because children tend to be healthier. As long as they're taking their meds, they're good. So anybody with chest pain, anything like that, then you got to go to the ER if they're type 1 or type 2.
All right. This has all been very great information. Thank you so much, Melinda. We really appreciate you spending the afternoon with us to share all of this.
Well, thank you. Thank you guys for your time, Tom.
All right. And that officially concludes our webinar. Thank you for joining us. We hope you will continue to prioritize the health of your children, and we look forward to seeing you for our next installment of this Let's Talk Children's Health series on Wednesday, March 19th from 5:30 to 6:30 p.m. when we will discuss asthma and allergies. Like and follow the STHS Children's Facebook page for more details on our future Let's Talk Children's Health webinars. And to view all of our previous Let's Talk seminars, all you have to do is visit sthsletstalk.com. Until our next seminar, stay healthy, stay safe, and please continue to prioritize your health and the health of your little ones.
At South Texas Health System Children's, your child's health is our priority. When they're ill or injured, we're ready to help. Our team includes on-staff pediatric specialists in infectious disease, cardiology, orthopedics, neurology, ear, nose, and throat, and more. Our round-the-clock care features the Valley's first dedicated children's ER. For more than 15 years, we've offered healing and hope for kids. And we're here for your family now. South Texas Health System Children's.
Where kids come first.